Hi everyone, thanks for listening to my presentations. Thanks for watching videos on my channel. I want to start talking today about a very familiar topic that could be confusing and controversial to so many, and that is syndrome of inappropriate anti-diuretic hormone. But for today, I will go over pathophysiology, the different types of SIADH, and how do we make the diagnosis. Okay, let's go. In the course of my presentation on SIADH in total, I'll be going over some times, and that will constitute SIADH lesson 1. So for lesson 1, I will cover times, definition, pathophysiology, types of SIADH, and diagnosis. Then there will be SIADH lesson 2, and that will cover causes of SIADH, the symptoms, and differential diagnosis. And we will wrap it up with SIADH lesson 3, and that will cover treatment from any angle to the other. As far as SIADH is concerned, everything we could do will be covered then. And of course, the warning or precautions will also be covered. So, times ADH, anti-diuretic hormone. Another name for it is vasopressin. So it's either I use the word ADH or vasopressin. It's still the same thing. Now, for you to understand what ADH is all about, that is to non-medical personnel, let me define diuresis. Diuresis is increased production or excessive production of urine. So let's go back to ADH again. So something working in the opposite direction of diuresis is the ADH. So if diuresis is increased production or excessive production of urine, it means ADH is preventing increased production or excessive production of urine. In other words, ADH is holding water into the plasma. It's keeping water inside the plasma, so not letting the kidney send out lots of it. So that is what ADH is all about, anti-diuretic hormone or vasopressin. That's exactly what it's doing. So we are now dealing with SIADH, syndrome of inappropriate anti-diuretic hormone. It means we have that hormone, ADH or vasopressin, preventing excessive production or excessive, excretion of urine, but it's working in such a way that is inappropriate. And what are we going to see? You should be interested now. SIADH is a disorder of impaired water excretion. There is an inability to suppress the secretion of ADH. And what are we going to be dealing with? More water will be retained. Remember the definition I've just given. It will then lead to a kind of dilution, and that will lead to low level of sodium relative to the entire constituent of plasma. So it's going to be giving us trouble as per the level of sodium. So we're going to have hyponatremia. So there is hyponatremia, low level of sodium, and the osmolarity will also drop, hypo-osmolality, because it's helping to retain water. It's not sending it out. The urine osmolarity will be greater than 100 milliosmoles per kg, because The little that will seep out, will get to the urine. Urine sodium will be above 40 milliequivalent per liter. The normal is 40 to 220 milliequivalent per liter per day, and so many laboratories will even pick 20 milliequivalent per liter. Here, when you do your electrolyte assay, the level of potassium will be within normal range, and the pH will also be within normal range. There will be decreased serum uric acid, because it's not that the kidney is not functioning well, okay? The kidney is functioning well, but the ADH is holding more water into the plasma. Osmolarity, and please take note of that. I'm not saying osmolarity. This is osmolality. It's going to take a separate presentation to distinguish between osmolality and osmolarity. But for this purpose, I'll stay on osmolarity alone. Serum osmolarity should be higher than urine osmolarity. The serum is expected to be between 275, and it depends on the laboratory value anyway. Different labs will give different values or range. So if you go through all the literature, you're going to find either 275 or 285 to 295 milliosmoles per kilogram. Urine osmolarity, on the other hand, is expected to be between 40 to 100. Some will choose 50 to 1,450 milliosmoles per kg. The average for urine osmolarity, if you go to some literature, is between 500 and 850 milliosmoles per kg. But the takeaway here is that the serum osmolarity should be higher than urine osmolarity. The pathophysiology. Plasma sodium concentration is expected to be a factor of exchangeable sodium plus exchangeable potassium divided by total body water. So you have a clue now that the plasma sodium concentration will be how much of the sodium that could be exchanged and with how much of the potassium that could be exchanged, and you divide the addition of both by the value of total body water. Appropriate ADH should lead to concentrated and low volume urine. That is, the water is kept in plasma. So the little that will get out of the kidney should be concentrated and low in volume. ADH plasma level is directly proportional to the degree of urine concentration. Still on pathophysiology, in syndrome of inappropriate anti-diuretic hormone, drinking more water doesn't dilute the urine. Then you need to become suspicious, because normally when the patient is drinking more water, the urine that will be produced is expected to be more diluted. The urine is still highly concentrated, giving us a clue that there is a high level of ADH in play. More water is retained, and we have increased total body water. Therefore, the plasma sodium level will drop, so decrease sodium. Then we are faced with hyponatremia. There will be increased urinary sodium excretion. Of course, we have two compartments, right? We're talking of plasma sodium, we're talking of urinary sodium. So if plasma sodium level is dropped, then what is happening? Urinary sodium is high. Further decreased plasma sodium level will occur. The more the urinary sodium excretion is increasing, the lower the plasma sodium level. Still on pathophysiology, someone might be saying, oh, how long is it going to spend on pathophysiology? When you know it, then you'll be able to salvage the problem. Okay? Usually, when plasma osmolality is less than 280 milliosmoles per kg, the ADH level of vasopressin will drop. Okay? ADH level of vasopressin level will rise when plasma osmolality rises above 280 milliosmoles per kg. Okay? Telling the brain that we need to do something. We need to retain water to handle this high osmolarity, because this high osmolarity is not good for the cells. So let's retain more water. That is normal situation. That normal homeostatic role of ADH is lost in syndrome of inappropriate anti-diuretic hormone. We're not going to get that. Now, types of SIADH. Oh, somebody is whispering to me, I've never heard it before. So SIADH had different types. There you go. Type A. In this case, we're going to find situation where there is excess ADH secretion. This could be as a result of bronchogenic carcinoma. So the ADH level will be grossly elevated. Urine osmolarity will also be very high. In type B SIADH, we're going to have ectopic ADH secretion, and that will make the ADH level to be very high, and increased ADH is occurring, right? But we are going to have normal regulation by osmolarity. So in other words, there's increased vasopressin secretion, though the regulation or the normal regulation is by osmolarity. ADH could be within the normal range, or ADH won't drop with low osmolarity, or ADH won't rise with high osmolarity. In type C, we're going to have reset osmosis. Here, we'll be dealing with very low osmolarity, and ADH is not released. Okay? So there is direct proportionality of ADH with rising osmolarity. The falling plasma osmolarity will eventually be normalized. I think that is pretty fine. So somebody having type C will be asymptomatic, and you don't really need any therapy. In type D, there is appropriate release of ADH proportional to the level of osmolarity. But urine is still concentrated, even in the face of low ADH. This is likely found in hereditary syndrome of inappropriate anti-diuretic hormone. You want to understand that better? Pause, read my write-up, replay my comments. Type E, there is drop in ADH, and there is increase in serum sodium because of changes in baroreceptor signals. minute drop in volume or minute drop in blood pressure will lead to a large increase in ADH production. Also, a slight increase in blood pressure or a slight increase in volume will lead to a large decrease in ADH. Diagnosis. When we take our assay, osmolarity, electrolyte, blood urea nitrogen, and so on, that's renal function tests, right? We are going to arrive at SIADH as our diagnosis based on clinical presentation and laboratory findings. And the following will be what will guide us. When we check the osmolarity, there will be decreased serum osmolarity, less than 275 milliosmoles per kg. Then urine osmolarity will be greater than 100 milliosmoles per kg. That will be pointing to SIADH. Clinically, the affected person could have euvolemia, at least they are not hypovolemic, they are not hypervolemic. Then urine sodium will be greater than 40 millimoles per liter. When you check the thyroid, because hypothyroidism could be responsible, or when we go over the causes, we'll get that. When you check the thyroid, you are going to find euthyroidism. Now, your thyroid stimulating hormone T3, T4 will be within expected range. So you are not dealing with hypothyroidism, you are not dealing with hyperthyroidism. Normal adrenal function. No diuretics prior, because you are trying to rule out other situations that could present like this. So when it is not hypothyroidism and it is not adrenal dysfunction and the patient is not on diuretics and you are finding urine sodium that is greater than 40 millimoles per liter, you are finding urine osmolarity greater than 100 milliosmoles per liter, and you're having serum osmolarity less than 275, then you know you are dealing with something called SIADH. But you are not done yet. You check your serum uric acid level, and it's going to be less than 0.2 millimoles per liter. The urea is going to be less than 3.6 millimoles per liter, because that is not the cause of the problem, right? Serum creatinine will be low. And why are we concerned about all this? Because this is kidney problem, all these values will be high. Fractional excretion of sodium will be greater than 1%, and fractional urea excretion will be greater than 55%. If you give 0.9% saline, which is called normal saline, right, is not going to correct the anomaly. Isn't that wonderful? Then you begin to hone down on SIADH. The only thing you could do to test and then put your certificate down that this is SIADH is tell the patient to decrease fluid intake. And that is the only situation within short time, few days, that will give you a clue that you could handle this by decreasing fluid intake. And another thing you could do, then you'll be able to write on the record of the patient that this is SIADH. Give that patient 20 ml per kg water, okay? 4 hours after. Collect the urine and check. check the percentage of that fluid that has been excreted. The affected person with SIADH will produce less than 80% of the quantity of the urine you have administered 4 hours ago. And with that, you can put all these parameters together and then write. This is syndrome of inappropriate antidiuretic hormone. And that will mark the end of my first presentation, that's lesson 1, SIADH. The next time that I'm going to present, I'll be presenting lesson 2. So we'll go over causes, symptoms, differential diagnosis, and I know you'll be interested to get all those fast. Thanks for listening to my presentation. Kindly subscribe so that you can get my presentations immediately they're published. I appreciate that.